So good afternoon. We'll be talking about the management of adult cardiac ECMO. Most of the thing we have already discussed since yesterday and during the workstation. We'll just try to recapitulate and about the cardiac stunning, prevention and management. So first of all, let me ask a question from you. What do you feel, what exactly is the cardiogenic shock where we require a VA? Yes. When we say cardiogenic shock, what it means? Basically, you're right, absolutely right. When we have given an adequate amount of fluid, that is another thing which is important, that pulmonary capillary wedge pressure is more than 80, patient is adequately filled, but in spite of that, tissue perfusion is compromising and ultimately is leading to hypotension. The pressure is dropping down less than 90 and patient is showing a signs of hypoperfusion. So signs of hypoperfusion, how we understand it, how we look at it. It's better, it should be two-way communication, it's better if we have. Sorry? Okay. Oliguria, drop in urine output. Yeah. Cold clammy peripheries. Yes. Lactate level, exactly. So basically what happens, it's an imbalance. What is required and what is given. So as you rightly said, depending on which organ is having a hypoperfusion. If it's a brain hypoperfusion, if patient is conscious, he will start losing his consciousness. Peripheral, patient will have a cold clammy skin, lactate level will start rising, and there will be decrease in the urine output. And if you auscultate the chest, what will get? Crepitations is left ventricular filling. So this is how it presents. And then what happens? We start with the, after adequate filling, we start with the inotropic support, we start with the IABP, and then we land up with the thinking of ECMO, and if we start, it becomes too late and irreversible. So basically what happens, any patient who is developing a cardiogenic shock, the mortality goes very high, almost mortality rate is as high as 70 to 90%, and it increases fourfold if any acute myocardial infarction is not associated with the cardiogenic shock. So you can imagine that how much high mortality is there. It can be either the acute event, as we see in the acute myocardial infarction, or there may be some worsening of the old ischemic events, or maybe a non-ischemic etiology related with any fulminant myocarditis. It can be viral, it can be toxic, or any myocarditis. So what is important in this cardiogenic shock, that we should have an organized approach, rapid response, and trying to optimize the hemodynamics without compromising and improving the tissue perfusion. So what are the different etiology? We all know acute myocardial infarction, myocarditis of any origin, pericardial cardiomyopathy, decompensated chronic heart failure, or post-surgical shock, cardiac shock, or septic shock where actually there is a severe LV dysfunction, or there is a biventricular failure, or patient is having a malignant arrhythmia. So what we achieve with the VA? We achieve both respiratory as well as the cardiac supply. So it basically, what it does, yes, what VA ECMO does? It supports the cardiac output. The primary function is the supporting the cardiac output. And we plan the ECMO in those patients where there is a reversible pathological process and it's acute and there is a high chances of mortality. So basically when we talk about a VA ECMO, it supports the partial hemodynamic support so that there is a ventricular decompression and augmentation of the perfusion pressure. Because what happens when there is a cardiogenic shock, the pulse pressure becomes narrow. So that compromises the perfusion, and with the help of ECMO, we try to support and decompress the heart. So what are the advantages? We can start immediately the patient bedside. We don't need operation theatre or other areas. And we can do a peripheral percutaneous ECMO quickly, as early as possible we can start with. And even we can go to the other center and we can immediately start ECMO without shifting the patient, and once patient is stabilized, he can be shifted. And if required, we can convert it to full cardiopulmonary support. And basically it allows time to think that what exactly could be the cause. Sometimes it is, you're in dilemma that what exactly is happening. So it gives you a time. And usually it's not as costly as the LVS devices or other therapy, and it's a validated system for bridge therapy. This we should always keep in mind. So basically, if we look at the cardiogenic shock due to the acute myocardial infarction, at what places we can use ECMO. This is one. We are planning for PCI, continuous coronary intervention or surgical intervention, but patient is not stable. He's having a continuous ventricular fibrillation, CPR is going on, and then we revive, the blood pressure is just 70. And this is what usual scenario in the acute MI patients when they are presenting to the emergency department. And this is the place where we can first put the patient on ECMO, stabilize, and after stabilizing, put the patient for PCI. Our other area where we have done the primary PCI, and after that, probably as the patient is having a reperfusion, malignant arrhythmias, are still in the cardiogenic shock and not showing improvement, then we can place these patients on ECMO support. So what happens? If suppose there is a cardiac arrest and you have placed your patient on ECMO, so how we should approach? So you have put it a patient and you are uncertain about the neurological status, because if you have done a CPR, even a high quality CPR for 15-20 minutes, you may not be sure about the exact neurological status. So you have put a patient on VA with a bridge of decision that what next to be done. So either there is a complete end organ functional recovery, neurological recovery, and cardiac recovery. This is what we actually look for. So it's a bridge to recovery. Once patient recovers, we take out the ECMO and patient is fine. But what happens if there is no neurological recovery, but end organs are improving, renal functions have improved, other organs are doing fine, and even there is a cardiac recovery? So what to do? So this is the place where possibly we can think of withdrawing the support. And third, patient is neurologically fine, patient and organs functions have recovered, but the cardiac recovery is not up to the mark. So what's next to be done? This will be a bridge to transplant or bridge to other therapies. So what are the different cannulation? We have already discussed these. Cannulation, it can be either peripheral or central. Central usually are used for cardiac surgical procedures. Peripheral, which we actually do by Selzinger's technique or modified Selzinger's technique, where we open and then under vision we follow the Selzinger's technique. And here the femoral or internal jugular vein for the venous access and femoral axillary or carotid approach for the outflow access. So this is how it looks like, central or peripheral. And this is the whole component of the VA ECMO system. We can see the blood is being deoxygenated, blood is being drained, then it is passing to the blood pump, and finally with the membrane and with the oxygen blender and the heat exchanger, it is finally returning back, and here is the bridge. This is how it looks like. So basically what happens, it provides almost 60 to 80% of the it supports the cardiac output almost 60 to 80%. Because what will happen if you try for 100%, the ejection will be lost and possibly there will be myocardial stunning. So basically, this flow of the VA ECMO depends on two variables. One is the static variables, that's the cannula length and diameter, and dynamic variables, that's the preload, afterload, and the pump speed, what RPM we have set for. So we say it's a preload dependent when we use the centrifugal pump. These centrifugal pumps are preload dependent and afterload sensitive. What it means? When we say preload dependent means if patient is hypovolemic, then there will be a chattering, it will not be a sufficient flow. And afterload sensitive means if a patient is on high vasopressors or patient's afterload is high, blood pressure is very high, then probably you will not achieve the adequate flow. And RPM you have to adjust according to the patient requirement, how much it is required. Cannula length and diameter, if the length is too high, the flow, there will be resistance to flow. And diameter, so it is said that for adequate flow, you should have a minimal length and the maximum diameter of the cannula. Circuit component, basically all the circuit component are chosen to achieve a flow of 50 to 75 ml per kilogram per minute of a flow in an adult patient. For us children, it will be above 80, and for a neonate it will be around 100. So how do we manage? What exactly is our goal? So basically, we want to maintain the cardiac output. This is the patient-specific goal. We want a flow with ejection. So we are maintaining, supporting the cardiac output, but we are trying to maintain the ejection itself. And we try to use the lowest RPM to prevent the hemolysis. And the minimum RPM, what we decide that whatever the appropriate cardiac output, which is actually providing the adequate tissue perfusion. This is what we target, so that there is no hemolysis or minimal hemolysis. And we titrate FiO2 for whatever saturation we are targeting. And we first minimize the FiO2 on ventilator. And then we look at the blood gas report, PO2 levels, and accordingly we reduce the FiO2 from the ECMO side. And we titrate the sweep gas flow depending on the carbon dioxide level. Right? So if we talk about the managing these patients who are on VA ECMO, managing these patients normally as you do in the care of any other major surgical patient. So what is different? Why it is different and need to be discussed? Because the major addition is the only ECMO machine. So what we should look for, our focus should be monitoring both patient as well as the machine. What should be our ventilatory strategy? Anticoagulation, hemodynamic management, fluid and electrolyte management, hematological management, nutritional management, and complications. So first of all, when we need to manage so many things along with the machine, we should have a dedicated team. The dedicated team, the perfusionists, nursing staff who are trained in the managing ECMO, and the doctors, there should be multidisciplinary. So cardiac surgeon, anesthesiologist, ICU specialists, other specialties like infectious disease physicians or other physicians, chest physicians, general physicians, they should be a part of the team along with the nutritionist, physiotherapist, and occupational therapist. And what is most important is the vigilant monitoring, not just that putting a patient on ECMO and sitting. We have to be very careful, and we should always think that something is wrong until proved otherwise. Then only probably we can think of a successful ECMO. So this is how the team should be, and why this is so. There should be a good communication between the team. Then only probably we can think of a successful ECMO run. So vitals, ECG rhythm, we should try to maintain the organized rhythm. Why this is important? The moment there is a rhythm change to the ventricular fibrillation or any ventricular tachycardia which is not ejecting the blood, there will be LV distension which will increase the myocardial oxygen requirement and stress. So ECG rhythm, a continuous monitoring of the ECG rhythm is the must. Along with that, you look at the pulse rate and our heart rate, because if there is a persistent tachycardia in spite of supporting your patient on VA ECMO, it means probably your flows are inadequate or oxygenation is insufficient. So you need to improve on the flow, or you need to improve on the oxygenation. Invasive blood pressure monitoring, in arterial pressure, the target should be above 60 to 70, but that varies depending on the patient condition and looking at the other parameter as well. But what is most important, that the pulse pressure difference should be more than 10. If it is less than 10, it means there is a possibility of stunning. Temperature, a continuous monitoring of the temperature, respiratory rate, whatever you have said on the ventilator, and urine output. That's another a good indicator. The color, quantity, that's important. Why color is important? Hemolysis, right? And quantity, it will give you a very good guide for tissue perfusion. Because if a good amount of urine output, it means that tissue perfusion is sufficient. Arterial cannulation, this is the important thing to monitor these patients who are on VA ECMO. If it depends actually on the site of arterial cannulation, where we are. Basically, it's the merging of two flows. One, the native flow, other is the ECMO flow. So where there is a convergence of the flow, that will decide that from where you should do the sampling, so that you get a good idea about the oxidation. So if the right common carotid artery is being used as arterial cannula, so where the mixing will be, it will be aortic arch. So you should avoid the right radial artery in this situation. The other area should be used for the arterial cannulation for checking the blood pressure and oxygen saturation. The right axillary artery, in this arterial cannulation in the right axillary artery, again the location of mixing is the aortic arch. Again, we should avoid the right radial arch. If the cannulation site is left axillary artery, then we should avoid the left radial arch. But if the femoral artery has been chosen, which is the most common for the VA ECMO, in those situations, its preferred site is the right radial artery. We should avoid other areas to monitor the blood pressure as well as the oxygen saturation. But if we have done the central cannulation, then there is no problem. Any artery can be chosen for the monitoring exam. So why this is so? Because there is a possibility that if we have put our patient on the femoral VA ECMO, once the cardiac function has started improving and lung functions have not improved with the poor lung functions, what is going to happen? Because the ECMO flow, the moment cardiac ejections are better, the upper part of the body will be mainly supplied by native lung. So what will happen? It is not well oxygenated. In those situations, upper body, including the coronary circulation, brain circulation, they will get hypoxemic. That's called as North-South syndrome or Harlequin syndrome. So in that situation, sometimes it becomes so extreme that the head of the patient becomes blue. So you will find that lower body is pink and patient is hypoxemic, and especially the brain and the coronary are getting compromised. So in those situations, the right radial artery cannulation, sampling from that artery and oxygen saturation from the right side is a crucial. How to manage this? First of all, ventilatory setting, because your ventilators is already, patient is on ECMO and it's on the base setting. So you can increase the FiO2, you can increase the PEEP and other parameters, I ratio can change so that you can improve the oxygenation. And you look for the etiology, why it is happening. Suppose there is a pneumonia, there is some reason for that, so you can start antibiotics and other treatment for that. Or if there is a mucus plug, you can suck it out, do a bronchoscopy and suck it out, and it can improve. Or alternatively, axillary arterial cannulation can be done to improve the oxygenation on the upper part of the body. But one should keep in mind, you can't put a bigger cannula in the axillary artery. Or we can switch over another simple method, VAV cannulation. Here what we do, we cannulate the right IJV and it connects with the arterial side, so that the oxygenated blood is going on the right side, so that you can improve the oxygenation. At some time, if the cardiac functions are absolutely fine, so we can stop the VA ECMO and we can switch over to the VV ECMO. So what we look on the patient, basic target is the looking at the gas exchange and mainly the tissue perfusion. So we look at SpO2. SpO2 will give you an indirect guide for peripheral perfusion, because SpO2 will appear on the monitor only when there is adequate perfusion on the peripheries, right? But if the patient is hypotensive or in shock or on the high vasopressor, so vasoconstricted, in that situation you might not get an appropriate value. Again, monitor the right side. What is another important thing is looking at the mixed venous oxygen saturation or central venous oxygen saturation. So from where we will get mixed venous? From PA. Do we put PA in all cases of VA ECMO? Yes. Who said oxygenator? Absolutely fine. We can always take a pre-oxygenator. That is the right place, because you are not going to put PA catheter in every case. So it is always preferable to take sample from the pre-oxygenator end. That will give you a good idea of central venous oxygen saturation, and which correlates well with this. Why it is important? Because when we check the central venous oxygen saturation or mixed venous oxygen saturation, it gives you an idea about the oxygen extraction. That what is the oxygen extraction ratio, and that will tell you how much oxygen is being utilized, and how much. It is not important that how much is available, but how much is being utilized and how much is being returning back. That's the most important. So we look the balance of oxygen delivery and consumption, and simply we can look at the oxygen delivery by looking at cardiac output, hemoglobin levels, and oxygen saturation, because arterial oxygen content basically depends on these two factors, hemoglobin and oxygen saturation. So if you have adequate, if suppose there is a is very low mixed venous oxygen saturation, in that situation you look at cardiac output, you look at hemoglobin. If hemoglobin is low, you can increase it and you can improve the oxygen delivery. Normally it is around 60 to 80%, but if it decreases below 50%, then definitely you should look for a reason and you should treat. Then lactate levels is another good guide to look for the tissue perfusion. Usually lactate levels should be less than 4 after 48 hours. There should be a decreasing trend, and should in next 48 hours after starting the ECMO, it should come down below 4. If it is not so, you should definitely look for a reason and how to improve the perfusion. Those reasons definitely should be checked for. And definitely capnography and tidal carbon dioxide is another good indicator to tell you about the native lung improvement function, improvement of the native cardiac function improvement. That if cardiac output improves, it will start showing a improving traits. What we look on the ECMO parameter, 3 things we should focus: accuracy, efficacy, and safety. These 3 things are important. How to check the accuracy? We look at the hardware. Check the circuit. That's the most important thing, that we should look for a clot, air, any bubble or any leakage on the circuit, and it should be done on hourly basis. Before something major happens, you should be able to identify, pick it up and manage it. Then you look at the blood flow rate. Blood flow rate, because what happens, whatever RPM you have set, so in those setting RPM, how much is the cardiac output? It should not be fluctuating. Suppose it is fluctuating very quickly. What it means? What it means? Great. Anything else? Wonderful. Patient is hypovolemic. Anything else? Sorry? Line chattering. Why? That's the one reason is hypovolemia. What else? Sorry? Why? Reason. See, you have to be quick enough to think in this situation why it is happening, because your action should be correct and should relieve the problem. Yes, it can be wonderful. It can be positive intrathoracic pressure. Check the ventilatory setting. Pneumothorax, yes. What else? Think for a simple cause. Some more simple cause. Pneumothorax will not happen because your ventilatory settings are on minimal. So least likely, yes, हो सकता है, definitely हो सकता है, but cardiac tamponade, that is the most common reason. Your cannula is abutting against the arterial wall. It happens. Patient, the staff is doing some care and the cannula is against the arterial wall. Venous wall, sorry, your venous wall. So venous drainage is compromised. In spite of there is a multiple holes, but it is possible you have put a cannula which is not of sufficient size. So that is not draining appropriately. So these are the very common reason which we should think along with the other uncommon reason. Then gas flow rate, blood flow rate, gas flow rate will decide about the ventilation part, because there are 2 parts whenever we are on ECMO. One is ventilation, other is oxygenation. Ventilation means washing out carbon dioxide, how much carbon dioxide is being maintained, and oxygenation means how much oxygenation is being maintained. So gas flow rate will tell about the how much is the PCO2. Accordingly, you adjust the sweep gas flow rate. Then revolution per minute RPM, that will tell you about the cardiac output, and you look at the patient, clinical judgment, looking at the lactate levels, looking at the other parameters, you decide that whether it's a sufficient, this cardiac output is sufficient or not, and you manage the ECMO FiO2 to a minimum depending on how much is the PaO2 level. Then you look at the oxygenator, looking at the delta pressure, you decide, and you look at the post-membrane blood gases to make a decision that when to change the oxygenator and where exactly is the problem. You check the pressure, pre-membrane pressure and post-membrane pressure. And what we find with this, how much it should be now, how much should be the delta pressure, above which you will think that there is a problem? Yes? Okay, great. And what about oxygenation? Post-membrane blood gases? Sorry. Above 100, if it is not compromising your lactates, if it is not compromising any other parameter, probably you will not mind to accept above 100. Okay? Great. Efficacy. This part is assessed by clinical and biochemical parameter. Your clinical judgment that how efficacious is the ECMO going. Means whether your patient is showing improvement, look at the rhythm, organized, look at the blood pressure, well maintained, look at the patient, he is doing fine, lactate levels normal, metabolic acidosis corrected, and passing a good amount of fluid. These all are signs that your ECMO parameters are efficacious and you are maintaining an adequate tissue perfusion. So three things: MAP, mixed venous oxygen saturation, and lactate levels. You focus these three things and you understand that whatever your parameters are sufficient. How you look at the safety, that whether there is a problem with the machine, you look at the pre-pump pressure, post-oxidative pressure, and pre-oxidative pressure. And you maintain the appropriate coagulation status with the ACT of 160 to 180, and you check the APTT in those cases where you your coagulation abnormalities, you find that there is some clot in the circuit or there is a bleeding tendency. In those situations, you look for APTT. Platelet counts and antithrombin 3 level when ECMO has run for a few days and you found that there is some clot formation, or heparin requirement has gone significantly up in those situations, because if heparin requirement, infusion requirement is very high, suppose it has become doubled or triple of the baseline value, it probably the antithrombin 3 levels have gone down. So you need to replace with the plasma probably, and you can reduce the requirement of heparin. Then you look the complete blood count and you monitor the plasma free hemoglobin. This will give you a good idea that there is no hemolysis. Normal should be less than 10 milligram per deciliter, but if it is around 50 or above 50, then it should be alarming. Then you look at the bilirubin and LDH again to check for the hemolysis and urinary pH and hemoglobin urea. And definitely a clinical judgment and radiological confirmation of your cannula position, that is again important. You target a mean arterial pressure around 65 to 80, in neonates 40 to 60, and basically your target is a mixed venous saturation around 70 and lactate should be less than 4. So and maintain adequate preload, which you keep again looking at using the echo for this is a very important. When a patient is on ECMO, you should make a habit to at least use the probe to check the cannula position, to check the chamber pressures, chamber volumes. This is important because anything is happening, you can't wait for the cardiologist to come and do the echo. If you know it well, just put a probe and you can monitor the chambers, you can check the valves, you can check the position of cannulas, and you'll be happy, okay, fine, adequate preload is there, there's no problem with this. So blood flow rate, depending on how much is required, keep reducing the vasopressor. Again, when we are talking about a hemodynamic management, the moment patient goes on VA ECMO, start reducing the inotropes and vasopressor quickly. Because again, as we say that it is a afterload sensitive. So if the afterload is high, the ECMO flow will not be sufficient. So reduce the vasopressor as early as possible, and sometime to maintain the cardiac contractility, you need a inodilator in the form of milrinone or dobutamine. And always look at the, keep checking the echo and look at the cardiac output, whatever you are generating. And if you have any advanced hemodynamic monitoring, you should check the cardiac output along with that. When the patient is on ECMO, why there may be some hypotension. The possible causes may be inadequate preload. Patient requires an initial phase. In the first 24 to 48 hours, patient always requires good amount of fluid. The blood hemoglobin, there is a drop of hemoglobin, or there is a loss of ejection or cardiac contractility. So to manage this, give adequate amount of fluid, try to maintain hemoglobin if hemoglobin is less than 10, and occasionally you need vasopressor in this situation if it is there is a vasodilatory shock. Then we have discussed this cerebral and coronary hypoxia already. Then myocardial stunning. This is another complication. Usually happens in 1.5 to 7% of cases, which more common in the neonate, but it's reversible. What is important? The shortening fraction decreases more than 25%. Usually it recurs within 48 hours. It is basically characterized by loss of arterial wave contour. So there will be no ejection in spite of some electrical activity of the ECG. And there is a decrease of pulse pressure. Usually it is because of severe LV dysfunction, or there is a high bronchial return to LA and LA has distended, and there is an incomplete venous rhythm capture, or there is a aortic valve insufficiency. Aortic valve is not opening. Because it is not opening, so there is no forward ejection and LV is distending. Or there is some electrolyte imbalance. We'll just have a video that how it looks like. Can you appreciate this? Now we'll see once it is recovered. Can you see the difference? This is the recovering, almost recovered. So you can see the good contractions. So what exactly happens once the ejection is lost? The problem is there is a decreased LV ejection, which will lead to distension and dilatation of LV. And this dilatation of LV will increase the myocardial wall stress. Rather than, so there will be an imbalance between the oxygen demand and oxygen supply, which is already compromised. Your ECMO is increasing afterload and there is LV distension also. So this will further put a stress on LV. There will maybe mitral valve regurgitation. Pulmonary edema, what will happen? Suddenly you will see that there is a frothy secretions are coming, or pink secretions are coming through the endotracheal tube, or there may be pulmonary hemorrhage. And if stunning is for a long time, then there may be thrombus formation. So how to manage? Non-surgical interventions. First of all, make sure that there is adequate preload and start with a small dose dovitamine, melvinone, or resveratrol. We can decrease the ECMO flow for some time so that we give a time for ejections. And if there is any electrolyte imbalance, try to correct it, mostly potassium. And mechanical support, again, with the IABP, or we can use the LV decompression methods. How we decompress the LV so that LV distension decreases? It can be percutaneous, using the Impella device, or transseptal LV cannulation, or atrial septostomy, or we can do a surgical LV decompression directly by cannulating the LV apex, or we can do a direct LA cannulation. And non-invasively, we reduce the ECMO flow and we support with the inotropic support. This is the Impella device, which actually we place near to the aortic valve so that it reduces the afterload, or we can use the TANDEM heart for that. These are the area where we are doing the venting. This is the venting through the LA. This is the LV venting. This is the PA venting. This is the PA venting. So this is how we do the venting. This is the diagram where retrograde decompression, transpulmonary retrograde decompression has been. Body weight, and the relative pressure should be less than minimal around 30, and we should give a low P. Higher ventilatory setting is required when there is a north-south syndrome. In those situations, definitely you have to step up the PEEP as well as the FIU. And then you should do a pulmonary toilet, means you should do a bronchoscopy if required, because patient is hypernized, there is a high chance that there may be bleeding. So you should be careful, but if required, you should do a bronchoscopy. And ultimate goal is extubation and managing awake with the spontaneous breathing if lung function is adequate. So if the patient lung function is okay, we can always extubate this patient, and further we can reduce the VA. So how do we assess that there is improvement in the oxygenation? Improving lung function, if the flow is constant and your blood gases are improving and your tidal volume is absolutely fine and saturation is improving. And at a constant cardiac output, if there is an increase in the ECMO flow, our ABG with the saturation we are taking from the right radial artery, and this is showing improvement, or even the pulse oximeter. So we need to reduce the ventilatory FiO2 before decreasing from ECMO. First we reduce the ventilatory FiO2 and then we reduce the FiO2 from the ECMO. And carbon dioxide basically depends on the oxygenator surface area and sweep gas flow, basically on the sweep gas flow. So depending on the PaCO2 level, we keeping increasing or decreasing the sweep gas flow. So pre-ECMO, most of the time when you are putting a patient on VA ECMO, you don't have a time, but if time permits, you do a routine investigation and you assess the coagulopathy, you prime the circuit and you give the, for that you give the unfractionated heparin boluses prior to cannulation 50 to 100 unit per kilogram of body weight, and you check for the ACT. And if the ACT is less than 300, you start with the infusion at a 10 to 20 unit per kilogram per hour, and requirement is increased if the urine output is very high, or there is a, you have given the platelet transfusion, or you are using another modality like a CRRT, or while weaning also you need to keep the higher doses of the unfractionated heparin. While monitoring, maintain the ACT of 160 to 180, and if you are using a APTT for the guide, it should be 1.5 to 2 times. Major bleeding, when we call it a major bleeding, when there is a bleeding, hemoglobin falls more than 2 gram per deciliter, our blood loss is more than 20 ml per kilogram of body weight over 24 hours, or there is a transfusion requirement of 10 ml per kilogram of body weight, or there is a bleeding in the retroperitoneal area or pulmonary, or it involves the central nervous system. So any bleeding which requires a surgical intervention, that is called as considered as a major bleeding. Another issue is fluid management, because this is in the early phase we give lot of fluid, so there is an increased circulatory volume, and because of surge there is a lot of third space shift of the fluid, and there is a transient reduction in the renal function. So what happens ultimately, it leads to fluid overload, which is associated with a high mortality. And another issue is the electrolyte imbalance, which is common. There may be hyperkalemia if there is an altered renal function, and these all may contribute to the arrhythmia and myocardial stunning. To assess the fluid status, our routine echo is important. We can use the stroke volume variation as a guide to give fluid or not to give fluid, or we should look for the responses to the fluid challenges, or we should check for the pre-membrane pressure. Urine output again is a good guide. Target a urine output around 1.5 to 2 ml per kilogram per hour on when the patient is on ECMO. So initially what happens, this is low or none, but once you start ECMO, there is an increased renal blood flow, so there will be increase in the urine output. And to control the edema, either use the diuresis, or if not working, then probably hemofiltration can be used. Sedation, basically in the daytime, if hemodynamics permits, sedation interruption protocol should be followed, and keep assessing the neurological status of the patient, because that is again important. You never know when the patient will have intracerebral hemorrhage. So assess people every 2 hourly and keep assess the neurological status of the patient at least 4 hourly or 6 hours. Again, enteral nutrition, this is important. Early nutrition, once your lactate levels are settling, it means your tissue perfusion is appropriate. Give enteral nutrition as early as possible. But do not give enteral nutrition when there is a severe metabolic acidosis or lactic acidosis, because that shows a poor perfusion and lead to gastroparesis and other complications. And we should always remember that's a part of the therapy, and it should be adequate calorie as well as adequate proteins. Monitor blood sugar and control it. A continuous insulin infusion may be required if blood sugar is high, which lowers the risk of infection if we have a tight blood sugar control. So the common complications, if you look at arrhythmia, hypotension, acute pulmonary edema. So if there is acute pulmonary edema, look for a fluid overload or acute heart failure. If there is a hypotension, the cause may be a worsening of cardiogenic shock, or ECMO-related problem, internal bleeding, which can be GI or cerebral, or acute pulmonary edema because of aortic valve closure, it's not opening due to excessive ECMO blood flow, or there may be thrombus formation in the left atria or left ventricle, because it may be because of under anticoagulation, or there is a stagnation of a blood inside the LV, or there is a differential hypoxia, which we have already discussed. Mechanical complication, which can be related to the either cannula or the circuit. There may be vascular injury while doing the cannulation. There may be trauma to the vessel wall, or there may be difficult cannulation, or there may be hematoma, hemolysis, or there may be embolism, and there may be limb ischemia. The other problem which commonly we face is the chattering, which we have already discussed. We have to adjust the RPM depending on the versus the volume. We have to ensure that the adequate volume has been adjusted, then we can reduce this. Another issue is the hemolysis. For that, we need to check the LDH and plasma hemoglobin levels, and we should assess the oxygenator for its function. Another problem, limb ischemia in the VA ECMO, which is again a very, very dreaded complication because you may land up with the amputation. The causes may be arterial embolism or hematoma compression. While putting a cannula, probably a big hematoma has formed, or there may be femoral artery cannula which is too large to allow a retrograde perfusion. So how do we monitor? Clinically, we should always check the temperature, color of the limb, hourly, and vascular Doppler should be performed to ensure that anterior and posterior tibial artery flow is adequate. The management is distal perfusion. As a protocol, we routinely put a distal perfusion in all our patients who are on VA ECMO. Our surgical intervention may be dangerous if there is suppose there is embolism. So embolectomy may be dangerous because patient is on heparin and switching over may be a very difficult problem. This is how a distal perfusion cannula looks like. The other problem is the LV thrombus, because if there is a motionless chamber with the blood stasis, means there is no ejection, there may be a LV thrombus. We should do a frequent PT or TE depending on what is available to ensure that there is no LV thrombus. And if it is, we can have a difficulty while weaning these patients because this LV thrombus can break, and if it's a big thrombus, it will be difficult to weaning from the VA ECMO. Sometimes you need to do a surgical removal of this, but again, it's a very difficult thing. Hemolysis, a plasma-free hemoglobin of 50 milligram per deciliter is significant. You will find a red or dark brown urine, elevated potassium, and unexplained new onset of renal failure. And patient will be icteric, bilirubin will be high. The causes, there may be clot in the circuit or around the cannula. Inadequate preload, which is causing a low suction pressure, so that is causing hemolysis. Or there may be intermittent inflow cannula occlusion because of chattering, and inappropriate high pump speed. These all can be the causes. We should monitor this LDH and plasma free hemoglobin level. The management depends on what is the cause. So increase the preload, adjust the pump speed, and rule out any cannula obstruction by echocardiography, and change the circuit if required. So next is the weaning from VA ECMO. Once the patient is ready, blood pressure has settled down, pulsatility has returned, and we are getting a good trace of arterial blood pressure. Inotropes are minimal, and CVP and TA pressures are normal. Then reduce the flow, look for the trial off, and then we can do a decannulation and wound closure. So trialing off, for that, we need a frequent evaluation by the ECMO team. We start trialing off by using the bridge, maintain adequate ACT, keep a frequent monitor of the ACT at that time by doing a trialing off, and step up the inotropic infusion, increase the ventilator setting, do echo while doing a trialing off, and monitor blood gases and mixed venous oxygen saturation. Once you are comfortable with this, then we can always close this. So these are the targets for the initial treatment when the patient is on ECMO. These are the levels, and these are the common complications which we come across while putting a patient on VA ECMO. Any question or any doubt if you have? This